Good morning, everybody. I think we are live now. If you just have 1 minute to introduce my panelist here. I have with me Dr. Saleh Ishlash from Saudi Arabia. He's going to touch on the procedure and analyze it. Dr. Talal Al-Jabbari from Saudi Arabia. He's a device expert in this live transmission. Also with the panelist group here, we have Dr. Abdullah Naimi from United Arab Emirates, Dr. Mohammed Subhi from Egypt, Dr. Nireen Okasha from Egypt, and Dr. Sultan al-Sultan from Saudi Arabia. Dr. Kamal, do you hear us?
Assalamu alaikum.
Alaykum assalam. Yes, so please introduce your team and introduce your case.
Sure. So I will give the introduction of the case to Dr. Fayaz, who is on my right, Dr. Fayaz Khan. I have a very good team. First of all, we welcome you here from Riyadh, Saudi Arabia. The weather is perfect. It's 22 degrees and cloudy. It's good for going out and camping. We have here my team, Ms. Samar, our scrub nurse, Ms. Nourayu is our scrub nurse, Mr. Arif is our also circulating scrub nurse, Jabir is our technologist, and we have also Sari is our CRN. We have also the anesthesia, Dr. Abdullah Saleh, and our anesthesia technologist, also Mr. Saad al-Ntayri. We also hear Milan behind the scene. Also, we have Mr. Faisal also from our CBT team. We welcome you here, and I wish that we can all have a good experience with this case. Dr. Fayaz, can you introduce the case? Please, can we get the slides on?
Milan, could you please? So, Assalamu alaikum and good morning, everyone. So, let's go next, please, Milan. So, we've got a 67-year-old gentleman on the table. He's a diabetic, hypertensive, dyslipidemic. He's got CKD. Creatinine is quite high, around 330, 350. He has treated and controlled mental health issues. He had a bioprosthetic AVR in 2015, and in the same year, he had PCI to ostial and proximal LED done, I think, before surgery. He has got a bit limited mobility due to osteoarthritis. Next, please. His echo showed mild to moderate aortic regurgitation, which is intravalvular, is a bioprosthetic valve. Ejection fraction is 50 to 55%. So this time he got admitted with symptomatic bradycardias, mainly sinus bradycardias, with exertional shortness of breath, with minor troponin elevation. And he had a PET stress, which showed 32% of ischemia in the myocardium, mainly in the circ and the LED territory. And he had a very low CFRs in the LED and circumflex, and he had drop in the ejection fraction with stress. So he had some high-risk features in there, which led to the cath. So can we go next, please? So we'll show you some still images because because of the CKD, we are taking very limited pictures in here. The angiogram was done less than like 15 mLs. So this is the right coronary artery. You can see the right coronary artery is a dominant vessel, and it's got about 50% disease in the proximal segment, diffuse disease, further mild diffuse disease in the distal vessel, and diffuse disease in the branches in the PL and PDA, but nothing for us to intervene today. Go next, please. So here, we're going to explain the left main has got a really tight lesion, the distal part, and the purple is the old stent, which is patent, but just some of that stent is actually protruding into the left main. And then he's got a very severe proximal circumflex disease and a further moderate lesion distally in the principal obtuse marginal branch. So next, please. So this is another just a cranial view to what we discussed, nothing new information. And go next, please. Okay, so because he had symptomatic bradycardia after the cath, he ended up having a permanent pacemaker because we didn't think that it was related to his left main. It was just sinus causes, sinoatrial disease. He was seen by the EP and he had a permanent pacemaker put in. He was discussed in the multidisciplinary meeting, and there were a few surgical challenges in here. He had a heavily calcified aortic root, previous cardiac surgery, mobility issues, and the NDT recommended to have PCI instead of surgery, and he was accepted. We had a meeting with the patient, we explained the pros and cons, and he accepted, and obviously he kindly accepted to be in the live case as well. Okay, next please. So our approach here is that we are femoral, and we have got EBU 3 guide 7 French, so that we can, because we need to cover the ostium in here as well. So this way we took a shorter guide for us, and we need a bit more support because of the bifurcation lesions. We put 2 wires, one BN and cyan blue, and then we have done some ballooning and we've done some IVUS so far, and we can skip the rest of the steps at this point because we'll leave that for discussion. So go next, please. So go next. So I think just a couple of slides, what we are going to discuss today in this, what we're going to learn from this case is whether we should go provisional or 2-stent strategy, what's the data in journal, what's the approach in journal, and especially in this particular case where we already have a stent in the ostium of the LAD. Next, please. So the second discussion point, I think, will be whether to use some other balloons, cutting balloons, not, drug-coated balloons, role of imaging in decision making, the limitation of imaging in this case. Next, please. This is the last slide, that if post-imaging showed then how we should deal with the ostium of the LAD, whether we should convert to 2-stent or should we stay provisional. Let's see the current images now. Go with what we've done so far, because we thought we should utilize the time when you guys were discussing nicely some other liftments. Okay,
so
Kamal.
we tried to give the minimal of contrast. So this picture, as you can see, there is very tight, like almost 99% true bifurcation disease of the distal left main, including ostial circ and ostial LAD. So what we did first was to wire both, and then we ballooned left main into LAD, we ballooned left main into circ, multiple ballooning, and then I think we took a picture here, yes. And as you can see here, just with ballooning, that ugly, very tight lesion, it has improved a little bit. So now we took up an IVUS afterward, and we IVUS both branches, the circ and the LAD. And Dr. Fayaz will go.
So just Kamal, just before showing the IVUS, let me just have a spin with the panelist, ask the panelist what they think of the case and what's the best approach.
Sure.
Dr. Subhi, I mean, we've seen this case. I mean, we agree that BCI is better than surgery because of the previous history of surgery, the calcified aorta. So what do you think of the case?
If this patient has no prosthetic valve or any valve, and you decide to give a CABG or PCI, is a question called the Xentax trial. I think it's a right coronary with 1-1-1 decision. If there is no prosthetic valve, PCABG is the winner. But if there is prosthetic or comorbidity of this patient, I think we think about PCI. So with the heart in number 1. Number 2, the second question, 1 stent or 2 stents. Actually, this is the angle is 70, size the circumflex is more than 2.5. It's a critical lesion of of the circ. So it's 2-stent strategy. What kind of stent 2-stent strategy? Because this angle, I prefer DK crush, number 1, or Kilot is the second option. Imaging, yes, essential for a kind of patient. I'm not doing imaging in every case at the beginning, maybe imaging after this. not at the beginning, maybe after.
Okay, so two-stent strategy for this case.
Yeah.
Dr. Neri?
I believe so that two-stent strategy is going to be, we have to think of it because the left circumflex is a large vessel. The OM branch is a big vessel. The lesion starting from the ostium to the proximal part of the left circumflex. So I think two-stent strategy from the beginning is going to be an option.
Dr. Saleh?
So I think in the left main, less is more. So if they manage to get one stent with optimal results, that would be fantastic. However, I do share the same concern. I don't think they would be able to, particularly with the proximal LED. So if they stent into the circ and really show us a great IVUS of that proximal LED, and they can leave it away, that would be great and fantastic. I'm not sure that will happen.
Okay, so please show us the IVUS images now, and then after the IVUS images, we'll ask also the panelist again.
So Dr. Fayaz will talk about the IVUS for you.
So I think we usually image all our cases before and after. Especially in this case, the IVUS is extremely important because if you look at we are going from the left main into the OM. So we really need to know what's the size of the OM, and we need to really select our tools really carefully, especially the stent, and how long, if you put a 3.5, say, in the OM, would that 3.5 will become 5.0 in the left main or not? So I think that's a very key question in here. And I need to know about the ostium of the osteal stent in the LED, whether it's, how is it covering the ostium or not? Is coming to the left main or not, because it really will shift the strategy maybe from a provisional to two stents. Sorry, I had a very busy night and I may be skipping some words. So
please describe the IVUS for us.
Yeah, so let's go to the IVUS. This is from the circ, right?
Right.
Okay, let's go to the top. Let's go to the top.
We went on first of all inside, then we pulled back.
Yeah. So this is from the OM, and you can see the OM is a reasonable sized vessel. It's got some eccentric calcium and a soft heteroma in between, but the calcium is not really a circular calcium. It's mainly around 90 degrees maximum at points, and the vessel size reaches up to 4 millimeter actually on the IVUS. Go back, please. Okay, slowly come down. Slowly come down. Okay, it's because we need to see the ostium of the. Okay, keep coming. Okay, stop there. Okay, so here you can see the ostium of the circumflex, and you can also see the ostium of the LED. And you can see the stent protruding slightly into the ostium of the circumflex. Coming down, keep coming down, slowly. Okay, that's it. So you can see a bit more. Down, and keep coming down, more proximal, that's it. So you can see here the stent in the floating in a little bit into the left main. That can go into our favor a little bit in here if we are sticking to the provisional strategy, I think. And keep coming down. Okay, let's go into the left main now. Okay, so that's the left main. So the stent is coming into the left main actually. And here, our left main is around 5 millimeter. So the IVUS was extremely helpful in this case in sizing the OM, sizing the left main, because we don't want very major discrepancy, and to choose a stent which can be expanded to the size of the left main. And it also helped us in terms of the extension of the stent into the left main. Any comments, and then we can show you the other IVUS.
Okay, so let me ask the panelists now. So what's your thought? I mean, now the IVUS showed that part of the LED stent is protruding into the left main. So I mean, you still. What strategy would you do there?
Yeah, I think my initial concern when I saw the coronary angiogram is there is some disease on the ostial LAD. Like we know from IVA studies that distal left main disease usually extend to the LAD and the circ as well. But having now seeing this IVIS and there is a clear LAD stent strut like protruding into the left main, it looks clear with no disease. I think it's ideal here to do provisional from left main to LAD. Then pot, rewire, and then you IVIS again. Just make sure that you cover the shoulder of the LAD.
Sultan?
I think I will go with the provisional sector left main. Then we will do imaging again after the provisional to make sure if we have any area where struts is not covered.
Abdullah?
I think I will go for two-stent strategy here, maybe DK crush. And I think I was forced to say this because of the stents protruding into the left main from the LAD.
So you mean that the...
Yes, and I
sorry, still two stents after
two stent strategy. I think it's difficulty of the angulation of the circumflex. So it's better to protect circumflex at the beginning. This is the way how to choose between either to provisional or to DK crush or kilot. Or sometimes
you stent left main to circ first?
It could be like one option. Option 2 is a DK crush. I mean, put stent circumflex and then doing DK crush by putting the LAD stent. Or left main circumflex pot and then provisional for the LAD. It could be this or that. But you have to protect circumflex. Is a lot of calcifications, more angulations, big size vessels. So you have to make sure that everything is good. So
Kamal?
Yes, Dr. Mohammed.
So what's your strategy now after the IVIS?
Well, it's our strategy is to go first with our, let's say we're gonna go initially as if we are doing kilot. So we're gonna stent into the circ. We will use about like a 3-5 stent, which actually can go up to 4-5, or might be also go up to 4-0 in the circ, and then deploy it. Take another picture and see what's going on. If it looks fine, then we will do just kissing balloon and pot. If it doesn't look good, we IVIS again. If the distal left main into LAD is we are not happy with it, then we would actually go ahead and put another stent.
So I'm going to say something provocative for the, just to be a little bit provocative.
What is it for us?
And that's because say the stent in the LAD was put just 5 minutes ago, then would it change anything? Would you still consider two stents? Because we are actually doing the two stents because the one stent is already there. So although we are going provisional for the current pathology, but the left main will be treated by two stents because already a stent there which is covering the ostium. So we're kind of doing like a tap or a T with a little bit of protrusion in here, which is already there.
For auto
I think we have a question here. This stent is floating in the LAD. So what are you going to do about it? This is the problem. You don't know how much are you going to inflate the stent of the LAD. It looks really smaller than the size of the LAD itself.
So. You are very right. The stent is very undersized and underexpanded. And our plan is once we dealt with the left main into circumflex, we will rewire into the LAD. We will use a 4.5 NC there, and then we'll re-IVIS everything, and then we'll see if we need to post-dilate that or not. I'm very hopeful we'll be able to post-dilate that, inshallah, because I don't see a heavy calcium around the stent. Yeah. So I think that's a very good point.
So Kamal and Fayaz, continue working, and we're going to discuss here, okay? And just show us what you are doing, okay?
Do we know the size of the stent of the LAD? Because we don't know if it is under-expanded or it is a small stent from the beginning. So this is going to make a difference in the decision, I think.
You did IVIS, right?
Yes, we did. We did.
What was the size?
We can show you the IVUS.
No, just tell us the size of the...
So the size seems like a 3.5 stent, and they're in a 4.5 to 5 millimeter vessel.
Okay, Hamid?
They don't dilate much.
Correct me if I'm mistaken.
Or restrict
Wasn't it one anatomy up front, right?
Yes.
So my question to you, panelists, why are we focused so much on IVUS? Because they did PTCA to the circ. It's super tight circ, right? Subtotal occlusion.
So what was the question is why IVUS?
Question, why are we so focused on the result of IVUS after PTCA in determining whether we go 2 stent versus 1?
No, I mean, the question here is that there is an old stent and the proximal LAD. We're not sure how much of that stent is extending into the left main.
No.
So
his question is good. If you are deciding to do 2 stents, don't do balloon dilatation. Do IVUS first, and then decide after that. This is your question?
No, it's 1-1-1. Very tight distal lift.
Okay.
Yes. It's actually probably most of us would go 2 stent. I mean, I just noticed that you're discussing the result of IVUS after they did PTCA.
I think the
discussion
PTCA
is done to facilitate the IVUS.
Absolutely, I know that.
Yes.
But we know that it's tight.
Yeah.
So how IVUS, in retrospect, would help us out?
I think the IVUS is going to change the strategy if you are doing. From the beginning, I didn't think this kilot will be a proper situation. We will go for the DK crush. Now we know that the LCX is a big vessel. It is a 4O vessel. So kilot will be an easier option.
Can I add to this? If you cannot pass the IVUS catheter, do pre-dilatation and see the IVUS criteria or OCT criteria. Why? Because sometimes you need debulking, which cannot be demonstrated just by angiogram. So this is the main issue of, but I agree with you that we need 2 stent strategy from the beginning, not to...
That's actually my question. It's upfront 2 stent strategy. That's what I meant.
Wait, I'd like to just say something. It's not necessarily a two stent strategy from the get-go. If the IVUS showed that there is metal in the LED extending back into the left main, then that's your first stent. Then you only need to put a second one. The question is really, do you need to put a third? So if you're saying I'm going to take a 2 stent strategy, then you're really saying I'm going to put additional metal left main into the LED. And studies have shown, we know that for a fact, that this will increase your target vessel revascularization. So adding this third stent will not provide us with additional benefit. And IVUS showed us clearly here that we're entering from the side struts into the left main. So it's a job half done from the get-go.
So Kamal, we see that you are putting a stent there. So tell us about what stent, the size, the length.
This is a 4O by 30 Onyx stent.
You're going to be starting from where? From the ostium of the left main?
Into the circle.
Okay.
But let me show you the final. Let's just take another.
So if you guys are happy, see, that's the area which is reaching up to 4 on IVUS in the OM. We're going to go very nominal pressure, and because 3.5 Onyx doesn't really take us to 5, it only go up to 4.75. So
we cannot wait too much here. Just
let us deploy the stent, and then we'll discuss that.
Picture.
Okay, let's go.
And do you think this stent is crossing from the stent which was protruding in the left main, or is it going, your wires are going through one of the struts which is protruding in the left main, or what do you think? Or you will crush the stent in the left main? So we have to know about this.
We're going to see it now.
No, I think the IVUS showed that we're crossing from the struts.
We're going to see that.
Yeah. The wire was crossing from
1, 2, 3, 4, 5, down.
How much pressure that?
It will be a kilo.
You only went nominal because distally we are pushing the limits in the OM. So we went with the 4O stent. We went only nominal, which is 12.
4O is big.
So, but 4O can take us to more than 5. So we are quite okay now in here.
Gonna comment
as long as we had
the stent.
On extent, how much it can expand it?
Yeah, so Onyx, it can go, if you use 3.5 or 4.0, it can take you up to 5.
Up to 5, yeah.
Yeah. The broadest
5.75.
expansion range is usually with Megatron, followed by SkyPoint, and then Onyx.
Well, I think these stents, Onyx, with Synergy, or Serio, this can reach up to 5.
This section in the
Samir.
that's all we are interested. Yeah, go for it.
Samir.
Yeah.
Okay.
The concern here is, or the critical point here is the stent protruding into the left main. With this technique, there is a chance that the struts protruding will conglomerate, will be deformed, and then it will create an area of irritation, turbulence, and also maybe a recrossing problem when we complete this procedure with the kissing. I would have done first, if this was a 3.5 millimeter stent and it was one of the two just mentioned, then a Zions or a similar one, it should have been expanded to the maximum before I introduced my stent into the circ in an effort to do what I probably would have done. We call it a T stent. The original stent in the LED is the first stent that was deployed, but properly, and then the circ stent will come beautifully against the struts of the other stent. Otherwise, I have a feeling that it will cause a re-entry problem because of the deformity that could be caused without playing with the size.
Samir, sometimes we put, when you deploy the stent left main CX, I put a balloon, usually I put a balloon in the LED at that time, and then I made simultaneous inflation with the balloon and stenting this. This is the only way not to put a stent and remove the wire and recross and put over. Yes, I agree about this.
Yeah, but we did not modify the LED stent. At least before
let's go back. Let's go back to the operators and see what they've done now. Kamal.
Okay, so now after stenting the circ, we're gonna do part first to the left main only and try to expand our left main stent. So we now, because we pulled out the LED wire, so we are sure that we're gonna not go into the behind the stent struts. Go ahead. So now we actually gonna do part here.
What's the size of the balloon?
Yeah, this is 4.5 balloon.
24.
And we went up to 24. That will give us like at least 5.2.
It's 4.8.
Yeah.
Ali?
Yeah, I second what the colleague mentioned. I was going to say that they have to optimize the stent and the ostium of the LAD first before they stent into the circ.
That's now done. It's
now done.
Yeah, so let's move on. So,
but also there's also some fibrotic tissue there, and that fibrotic tissue needed to be modified. So either cutting balloon or laser, probably. I don't know if they managed to really modify the plaque sufficiently so that they can actually, fully optimize the LAD.
So as Saleh remind me, they did in the beginning, they did ballooning in the LED and also in the circumflex.
And they demonstrated with IVUS that they are going through the stent, through the body of the stent, entering into the circ via the side struts. So the stent now from the circ into the left main is not going to crush the LED stent.
No, but I'm talking about the LED.
Optimization.
LED was not fully expanded. If you look at the
100%.
it was not fully expanded.
You don't know if it is not fully expanded or it was a smaller stent from the beginning.
Undersized.
We don't know if it is an undersized stent or it is not expanded stent.
They actually showed the
It's
IVUS.
actually, with IVUS, you can see, if you allow me, with IVUS, you can see that the stent is opposed, but the size is undersized. I mean, you can see that it is opposed to the.
So that's my point. You have to optimize it. You have to optimize before you stent across into the circ. That was my point.
Does it make a difference if you do it before or after?
Of course. You have to optimize it first, because if you're having trouble, then now you have a jailed.
So Ali, you're talking about doing like a bot, and that 2 millimeters of struts extending into the left main, right?
That and also the ostial LAD. Also, the ostial LAD needed to be optimized before you stent across.
So Kamal, as we discussed like earlier, like 10 days ago, I mean, these 2 struts going into the LAD, into the left main is going to bring a lot of discussion.
Hamad, I think it's wise not to make a perforation before doing left main stent.
Yes.
So it's just dilatation, and then stent crossover, and then pot, recross, kissing. Sometimes you put a balloon in there. This is, and then IVUS again.
No, but there is no expectation here that it will be a difficult cross. It's a single stent going circ into the left main.
He crossed now.
Yeah, he should be able to cross.
And with the pot, before trying to recross, it's going to make the life much easier. So it's going to separate the struts. The thing is that they were lucky enough, it's not the situation at each time, if you have a stent protruding in the left main, that you can really go from the stent strut into the LCX. Yes. You might be going under the stent, so you will end up crushing the stent of the LAD, and there where the problem is going to begin. Yes. So they were lucky to cross from inside the stent to the LCX.
I think this was the IVUS told us. If you look at the angulation, remember there is a disease in there. Yes. It's not a normal. This is not a normal left main, and it's not a normal ostial circ. So
definitely.
Yeah. So when you see, if there was a normal left main and a normal circ, then you would have seen some space in there. So I think the chances of yes, you're right that I don't think we took the struts because the IVUS would not gone and we would have troubles. But alhamdulillah, we didn't have issues.
Was it easy to cross?
Very easy.
What was the wire?
The wire, the great wires. So the great wires, one is BM and the other is C on blue.
Okay.
We recrossed with BMW wire.
Very good.
And now they cross. Yeah.
So what you are doing now?
Just going to create a little space. Is you are worried, we are worried as well that whether the balloon will go into the LED or not, because we need to work on the LED stent. So come back. Oh, you're already there. I see the dot. Okay, perfect. Okay. This is just a 2O balloon just to open the struts of that LED. Look, I think we have a little bit of normal saline in there. The burst. Just take time. Balloon burst. We went high pressure, so it burst the balloon. So we're just gonna go with a 4-5 to the LED now.
Yeah.
I think the question if they will be able to expand that original stent, because it's an unknown size, so we don't really know how far can they expand it.
I mean, by IVUS, when they did it, it was 3.5.
That's the final result.
The stent
it might have been a 3.0 stent that they post-dilated into 3.5.
And then kiss at the end.
I think we'll have to wait and see.
Yeah. Well, the question, under expansion is only to dilate or to put a DCP as well? For under expansion. Again.
So do you agree with our plan now? That we're going to optimize the LED stent and we're going to do IVUS to see if it's done the job or not.
Okay.
Do you agree with that? Any comments?
So now you're still sticking with the provisional stent, right? One stent?
I don't know.
Yes.
Yes, I'm comfortable with leaving the left main to LED without stenting.
Can I ask the audience here?
So just show of hands.
Yes, are you going to be satisfied with the kissing balloon, with the expansion of the stent, or you need a DCP?
Let's take a comment from Abdulrahman first. Abdulrahman.
Who is going to do just expansion? Can you raise your hands?
Sorry, just regular balloon.
Regular balloon.
Regular balloon.
Can you? The plan is to use DB at the end.
Sure.
DCP.
Who would put DEB in the LED?
A 50-50, yeah. Okay, go ahead.
Okay. I will do the kissing with 4 millimeter MC balloons. Kissing balloons to the circ, and circ is not optimized, LED is not optimized, and both undersized still. So you need to do kissing with 4 NC balloons, 2 4 NC balloons to the LED circ, then optimize with a 6 millimeter balloon to the left main.
Okay, so Abdurrahman, you agree there is no need for putting another stent there if we have everything covered?
The ostium of the LED is still covered with a stent.
Yes.
Not a metal. You
So
to double the metals in the distal left main.
No, you wouldn't put that balloon. You would just do a regular NC in both branches.
I think the IVUS is going to help
after
us.
the kissing and doing the left main optimization, you will see whether you need the stent after that or not.
Now you have a stent which is protruding just 1 or 2 millimeters in the left main, and now we have put a stent from the left main to the LCX. We are not that sure. The IVUS is going to help us in this. Is there 1 or 2 millimeter in the left main, in one side of the left main, which is not covered by any struts, because the stent is going from the left main to the LCX, and this is the LED balloon. We didn't cross from both sides of the stent. We are going from one side. So we might end up with an area in the left main which is not totally covered by stent material. So I think the IVUS, if it showed that this is the situation, so we will have to put either drug-coated balloon
pull back from LED to left main
to the left main.
There is a gap between the two stents, right?
Yes, I think so. Or what?
I think it will not show a gap, but I agree with you 100%.
If there is a gap, we will think at that time, 100%. Shall we cover it with a stent, a new stent, or a drug-coated balloon will help us in this. But if it is covered, I think it will be okay.
So after the kissing balloon, you pull back from the LED to the left main.
Yes.
To left main.
It will be important.
Kamal, what you will do now?
So now we actually gonna do high pressure ballooning of the ostium of the LED left main into ostium of the LED stent using 4-5 12 NC balloon, and then we will do IVUS and see how is it and take a picture, see how is it going. If it's okay, if it's acceptable, I would actually say that I will try to, then we would debate whether we need to put another stent or not.
Okay, you said you're going to also IVUS the circumflex back to the left main, right?
Right.
Okay.
So planning to optimize LED stent, optimize the circ stent, optimize the left main stent, then repeat the IVUS after that.
So, Abdullah Sultan, I mean, this shows also the importance of imaging in left main PCI. So what do you think?
I think we have to finish with drug-eluting balloon, left main into the LAD, just solo in one balloon, and then drug-eluting balloon, kissing balloon into
up to
both.
15.
Into both.
Okay, Sultan.
15.
I think IFAS will answer.
This is a 4O balloon?
Regarding the need of
This is a
additional
4-5
stent.
to optimize the
4-5. Okay.
Yeah, to optimize the old stent into the, which is in the LAD. We're going to go 20 atmospheric pressure, ostium, into the left main. This is 4-5 NC.
It seems there is a pathology in the ostium of the LAD, which is maybe like an in-stent restenosis or something.
I mean, this is now they did the high pressure with NC balloon. They will do IVUS now.
Yeah, for this pathology, you have to have a drug-eluting balloon to end the
We agree
procedure.
with that. We agree with that. We'll do IVUS and then we'll take it from there.
So great. I mean, you didn't do a lot of, contrast here because of the renal impairment.
Right, exactly. So far we gave about 60 cc of contrast on.
So we're going to do IVUS into the LED stent now to see how good and to show it to you as well. And then we will optimize the circ stent and then we'll do IVUS there as well. And this IVUS will also guide us how we optimize the left main stent. Probably we need a 5O NC to optimize that.
I think there is a problem with the live case and using contrast, because you want to show the audience what is the results and so on. We could have been more conservative using this volume of contrast.
Sometimes use a dynamic roadmap, even in live cases. I think this is the best way to minimize the contrast in such cases.
Live?
You are live.
Can you please do, okay, good, ring down is good. Okay, so this is the ostium, we're going now into the LAD.
Went nicely.
Went nicely, and this is the distal LAD. Okay. Can you start recording, please? So I'm pulling back now. This is, as you can see, the stent of the LAD.
Much better.
It's well expanded. Here we can see that. I think we have
9 to
probably
12.
missing a strut or two. I'm gonna go back to the left main, and it looks that everything is okay. The stent is well expanded.
Just towards the ostium, I think needs a bit more work.
Yeah.
The distal left main is okay. Kamal, can you go back with the eyes to the ostium of the LAD? Just stop. Stop, please. Stop recording. Go live, and we're just going to assess with the iris just only the ostium of the where the wire is. So this is a circ wire on the top. You can see around 12 quad. So the circ wire disappears. So it means this is the ostium of the LAD. And that's really covered quite nicely with a stent.
Yeah. So there is no gap between the two.
Yeah. Absolutely not. And we don't have a lot of stent metal in the left main here as well. So I think that looks very good.
But probably it needs more expansion a little bit.
I agree. So the plan is to do a little bit more
kissing balloon.
5-0 in the part in the left main at the end. We'll do before kissing. Yeah. So let's optimize the circumflex stent.
Sobhi, what do you think about the IBIS?
And I do a kissing and finally be a DCP for the LED.
You still do it?
Because already the results of the PTCA or following instant restenosis is not good. Maybe 30% restenosis LED. I'm sure that you need something around. I'll not put a stent instant, so I don't leave it. It's no harm to give DCP favor for the LED, but I will not stent the LED. I'm satisfied with the left main circumference.
Okay, so another question for you, the panelists, is now. So what would majority people would do in here? So we have kind of optimized, reasonably, not fully the LED stent now. And would you do? Do you do part or the left main optimization at this stage, or do you keep it to the end and the final kissing balloon inflation? What's your thought?
So two of the panelists think that after kissing you should do a drug-coated balloon in the LED, right?
Yeah.
I think there is no guidelines or no consensus to tell us to do this. It will only make us feel better.
Yeah, because I don't see any instant restenosis in there on the IBIS. It's pretty clear, really. So I don't see it.
I think if you have a full expansion and you have a good sizing by IBIS, then you don't have to do anything more.
But in general, any instant restenosis, maybe the mechanism of the LED, either endothelial growth here, it's underexpanded, and you put it to the full optimization, and then you add this in order to prevent the issues. This is for the LED. For the problem of the left main circumflex, already solved it. At the end, you mean repot of the left main by a higher balloon a long time. Yes.
So our strategy will be
just a comment about the instant stenosis and DCB. This is the class 1, guys. This is the guidelines, so it is evidence there.
Okay. Not for large vessels, so not for 550.
No. It's not mentioned small or large. It's instant stenosis in general. It's class 1 to.
Now we have already.
Trials are done on small vessels, not
but
large vessels.
Now we have extended or expanded the stent of the left main, the LED left main, with a 4.0 balloon, 4.5 balloon. So do we have that size of a drug-eluting balloon? He's going to expand it with a 5.
No, we don't have.
So if we are going to put a small drug-eluting balloon, we are not sure that the drug is delivered to the wall. So because of the size, the big size, so I don't believe that the drug-eluting balloon is going to do anything.
The audience, just show of hand, if you have good result with after kissing and the IBIS shows full expansion, who would still use a drug-coated balloon in the LED?
50-50.
Okay, if you only. So most of the audience, Kamal, agree with your strategy, doing kissing and finishing with a bot.
No contrast, just a silly.
So you said no balloon, no DB.
We agree. We agree with the no.
No drug-coated balloon.
Yeah, we agree. Because the majority, if you look at the trial data as well, they were smaller. They were typical instant restenosis. We didn't see any instant restenosis on the still in the stent. 16.
Talal, what's the
So
largest drug-coated balloon?
I'm not sure, but I don't think we have 4.0. I think the maximum is 3.5, if not mistaken, for DCB. 3? There is 4.5 as
Mr. Mustafa?
Thank you. From the data we know, even if you put a bare metal stent and the size more than 3, you don't need anything.
Yeah.
So in this case, I don't think we need the real drug-eluting balloon or another stenting, because you have a diameter of 3.5 with the stent previously and nicely, optimized right now.
Ibis, please.
In fact, there are 4 millimeter drug-eluting balloons, and they expand to 4.5 when we need them.
Okay.
Yeah,
Can I say something?
Yes.
we don't have evidence.
My only concern would be is if there is a small area of geographical miss of a stent, and you remember this stent was put in 2015, and we might actually now after disturbing piece of that ostial LED stent with the post-dilatation, there's always a chance that you might get some instant restenosis and regrowth of that tissue there. So I'm a little bit more inclined or have a low threshold to do balloon
Drug-coated balloon.
Or DCB balloon to the ostium of the...
What size you have?
What do you have sizes?
So we look for 4, 5, at least we need. So they...
Just go higher.
I didn't know that it exists.
Yeah.
Do you have a 4.5 DC balloon?
I don't think
we
so.
have 3.5.
Yeah. 3.5 will not touch the walls. Because already we use 4.5 and C, so...
Please deliver something.
Okay, good.
Okay. Guys, are we live?
Yeah, please show us the IVUS.
So on the pre-procedure IVUS, we didn't see any instant restenosis, by the way, in the LED stent. So I personally, me, Kamal, deferring here, we always take that quite nicely and quite friendly. We do defer, and we are deferring based on that. My point is that on the IVUS pre-procedure, we didn't see any instant restenosis, and we got a good result.
This is in the LED or where?
There is in the circ.
This is the IVUS of the circ. Now we are in the distal circ here, and we are going toward, pulling toward the stent in this proximal circ that we just put, and it looks very well opposed.
Hello.
Good sizing, I believe. Then we are going now into the bifurcation. It is going smoothly. There's some ostial narrowing here, but at the end we are in the left main. The left main looks okay, and it was also well opposed stent. We will go now into this. I think we can just be comfortable now.
Do kissing.
Do kissing and then do pot and finish it up with a final picture. What do you think, guys?
Yeah. We agree.
Agree.
In any case of left main, you have to be a repot. Is it a must? The question for the
final pot.
Repot.
Yeah,
we have to end with the pot, I think.
Kissing, pot. Kissing,
pot.
You have repot in any, whatever, it's not DK crush, it's kilot.
Final pot, always.
Almost repot, because this is a very important message to the audience. Yes.
With the bench testing, especially in left main, if you do kissing, you'll slightly deform the proximal part of the stent. And that's why you have to optimize it by doing a pot. When it comes to smaller vessels, if it's like LAD diagonal, it doesn't matter that much based on bench testing and based on imaging. But with left main, I think repot is absolutely necessary.
I think the main reason why we do final pot here is because during manipulation, sometimes you're guiding, you just distort your proximal part of the ostial left main stent. So, which has been associated with double mace on the Excel trial. So that's why we do final pot.
And I think the final part is to restore the geometry of the vessel, because we know that two balloons will give you an oval shape of the vessel, and the pot will restore the circular geometry.
Can I ask the panelists, if this patient has TAVI and the same pathology, what you're going to do for this patient? No surgery, okay?
Yes.
And then, do you any tips and tricks on doing left main in TAVI patient with this, in such case?
I think, I mean, who's going to answer here? Maybe Fawaz or
why do you think, Dr. Sobhi, why are you asking the question? Do you think it is going to differ, or
patient with
I think
TAVI? I mean,
no, it's completely different for the guiding, for the techniques. Yes.
I think it will depend upon the what type of valve.
Whatever evolutor is happening. Yes.
Exactly. I think it's the type of the valve make a difference. So low frame versus high frame. Low frame is easier to get a coronary access. High frame maybe a bit challenges, but both of them, the access, if we're talking about the first TAVI, it's easier. The real challenge will be when you go with the second. Valve and valve or TAV and TAV is going to be very difficult. So it's lifelong management in a patient going for TAVI is very important. Selecting the first device is very important.
Particularly if the first device was implanted, prior to this commissural alignment, and you don't really know if it was really properly aligned or not.
So the challenge is in cannulating and the support for your procedure.
Nowadays we have cases. We have cases coming. The future. I remember that in the old era of the PTC, we don't have cabbage. Now we have post-cabbage. Now TAVI, we don't have a lesion step. Now we have lesion because we have 20 years. So we have to accustom, we have to make coronary vascular in TAVI in another session.
Kamal, what are the balloons that you chose?
3-5-15 NCs.
Okay. So how do you do the kissing? Like alternating first and?
No, we will do it all at the same time.
Okay. So Sobhi, when you do kissing, do you do alternating kissing?
Yes, I'm doing. When I deploy the stent, I deploy the stent first and the balloon, and then I do alternating 16, 8, 8, 16, and then ending by 14 each. And
okay, so doing kissing balloon, first you do one vessel. Okay, and then
during deployment, I deploy the stent with ballooning of the back shop balloon and the.
No, here now. This is the final kissing. Does it matter if you do alternating or you do just one time kissing together?
It's already to have two stents, so it doesn't mean alternating. So you have equal pressure, and then repot with the main. The left main itself, it's with higher pressure.
I have a question.
The recommendation usually is you go with high pressure each time, one by one, okay? And then you pull it back a little bit and you go together like 12 or atmosphere.
Yes.
I have a question to the operator, Mohammed. Kamal, how is the patient tolerating this?
MashaAllah, it's very good. MashaAllah.
Hemodynamic is there.
How is the blood pressure? There is no.
Blood pressure now is. I'm not sure you see it on the display actually.
It's on the screen. It's stable.
Heart rate, blood pressure 130, 125 now, with heart rate of 69. And he is very comfortable, mashallah. Our anesthesia team, Dr. Abdullah, is doing a great job.
So sequential
Dr. Abdullah always doing a great job.
Sequential kissing and then final kissing. If we use actually already bigger balloons for optimization. So we use 4-5 in the LED and we use 4-0 in 7 plans. So And we already kind of done that, so I don't see the point at this point is to sequential ballooning. That's why we went straight for kissing.
So, Kamal, if you can give us just final angio, because we're gonna.
Sure. Okay.
The time is finished now.
Let's take a picture now for you guys, and hopefully it will be a good. I will try to make it better because the valve is in our way most of the time. Okay, I think this would be a good picture.
Just need to engage a little bit. Go ahead, touch me. That's it. That's it.
Okay, ready?
Okay. So, and we're actually using two, or flow on the contrast is 2 mLs and volume is 4 on the injector. So we're using very little contrast. I think we have a little disease segment in the OM after the stent. We're going to give some nitro and then might repeat that, and we'll look at the iris again.
Okay, Kamal, we'd like to thank you and the team for this great case.
Thank you very much.
We're gonna leave you now to continue of this small lesion distally, and great job.
I have urgent question to Dr. Kamal. What is the total contrast given, and when the patient will go for dialysis?
Okay, so alhamdulillah, we gave only 67 ml.
No.
Sorry, I'm reading the wrong stuff. 50 ml.
Very good. Thank you very much. Thank you. Great job. Thank you, guys.
Thank you very much.